The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerview.com/GKC860. Downloadable slides and practice aids are also available.
I'd like to welcome you today to our webinar where we're talking about turning the tides in targeted therapy for early stage EGFR mutated non-small cell lung cancer. We'll be looking at the latest data and practical guidance for thoracic surgeons as part of a multidisciplinary team on the new and emerging role of EGFR-targeted therapies in resectable lung cancer. I'm David Jones, Professor in Chief of Thoracic Surgery in the Druckenmiller Chair of Lung Cancer Research at Memorial Sloan Kettering Cancer Center in New York. I'm joined this morning by Roy Herbst, who's the Ensign Professor of Medicine at the Yale School of Medicine, Chief of Medical Oncology at the Yale Cancer Center, and Associate Director for Translational Research at Yale. Roy, welcome. We're going to have four items on the agenda today. We've already welcomed you and looking forward to the presentation. We're going to focus on the evolving role of EGFR-targeted therapy in resectable lung cancer. We're then going to have an oncology practum for thoracic surgeons where Dr. Herbst and I are going to discuss some cases and some important things to remember during the presentation, and then have some summary and take-home points for all of us. So with that, I'm going to get started and first talk a little bit about the unmet needs and room for improvement in early stage non-small cell lung cancer. We as thoracic surgeons always are operating with an intent to cure, but we know that there is a increased risk of recurrence. And this recurrence is really most notable in node-positive patients, meaning stage 2 or stage 3, but even patients who have larger stage tumors, or larger tumors like stage 1B tumors, also have an increased risk of recurrence. As you see here on this slide, studies that were published in the early 2000s and summarized in 2008 in JCO with the lung adjuvant cisplatin evaluation, or the LACE analysis, shows how much chemotherapy in an adjuvant, when given in an adjuvant setting, impacts overall survival. And you can see that the purple is the survival that's due to chemotherapy. And if you look at the bottom along the LACE graphic, approximately 3 to 13% of patients are benefited by the addition of adjuvant cisplatin-based chemotherapy following complete resection of their lung cancer. So clearly, adjuvant therapy can impact patients' outcome. As I mentioned, about 30% of patients with non-small cell lung cancer will present with resectable disease at the time of diagnosis. Adjuvant cisplatin chemotherapy is recommended for patients with resectable stage 2 to 3A non-small cell lung cancer, and in select patients with a high-risk disease who have pathologic stage 1B disease. The rates of disease recurrence following surgery remain high across disease stages, regardless, however, of whether they receive adjuvant chemotherapy. The role of tyrosine kinase inhibitors directed at EGFR genomic perturbations have become standard of care for those patients who have tumors with activating mutations in advanced and metastatic non-small cell lung cancer. And more recently, studies that we will talk about today have suggested that there is likely going to be a role for EGFR tyrosine kinase inhibitors in the resected setting in an adjuvant role. So what is the potential impact of adjuvant therapy after surgery? Well, first, it may eliminate the remaining disease. We would love that, and obviously would cure the patient. It may, in fact, though, just suppress remaining disease, rendering it rather dormant and control the disease and delay the onset for recurrence. The other third and less attractive option is that it's neither. It's ineffective or poorly tolerated and doesn't really have a role in clinical care. At this point, I'm going to turn the talk over to Roy Earps, who's going to talk a little bit about the evolution of EGFR-targeted therapy in non-small cell lung cancer. Roy?
Thank you, David, and it's a pleasure to be here with you this afternoon. Let's talk a little bit about EGFR-targeted therapy in lung cancer in the locally advanced and metastatic setting. While the molecular complexity of non-small cell lung cancer is becoming more and more known, it's amazing to me, since I was a fellow in the mid-90s and worked at MD Anderson in 1996, 1997, how we just began to target some of these pathways, and now we have 7 molecular alterations that are FDA approved, and leading the list is EGFR, ALK, ROS1, BRAF, V600E, NTRK, MET exon 14, and RET. So we've really begun to take the pie of lung cancer and make it more precise in how we can treat our patients. Well, EGFR by itself is an entire story. You can see that the majority of mutations are in exons 19 and 21, but there are also mutations in exon 20 and exon 18. Tonight we're going to focus mostly on exon 19 and 21, deletions in exon 19, point mutations in exon 21. And as I mentioned, look at this timeline. The first trials of these agents were in 1996-97, but it wasn't until 2004 that EGFR mutations were discovered. And that, of course, changed the world with 2008, the IPASS paper, which taught us that if you're going to use chemotherapy in advanced disease versus targeted therapy, you need to know the mutation status. Patients with the mutation status do better with EGFR inhibitors. Repeat biopsies began to become common in around 2010 so that we could target acquired resistance. We needed to figure out which of the TKIs was best, erlotinib, gefitinib, or afatinib. The first generation drug, second generation drug being afatinib. Then the third generation TKI was introduced to osimertinib around 2014. It worked against the most common resistance mutation, T790M, and that got approved for refractory disease. And then, of course, it was moved to the upfront setting. And now we're going to talk in 2020 about ADAURA, recently presented and published in the New England Journal of Medicine, looking at EGFR inhibitors in targeted patients in the earliest stages of lung cancer. So really a very nice story of taking biologic therapy all the way to the earliest settings. So here you can see the current approvals and indications for EGFR TKIs in metastatic EGFR mutation positive non-small cell lung cancer. I mentioned the first generation drugs. These are reversible EGFR tyrosine kinase inhibitors, TKIs. That's gefitinib and erlotinib. Then the second generation irreversible EGFR TKIs, afatinib and dacomitinib. Not only are these drugs irreversible, but they have a bit more of a pan-HER activity. They also have a bit more toxicity. Then the third generation drugs, these are actually irreversible drugs, but they're targeted just to the mutant EGFR TKI, so more specific, and that's, of course, osimertinib. And now we're even beginning to see some combinations. So here's an EGFR TKI plus a VEGFR2. So angiogenesis plus EGFR, and the combination of erlotinib and ramucirumab is approved based on a trial called the RELIGHT trial. So much progress being made with many available drugs. Well, let's go through some of the key data. This is the FLORA trial. This is a phase 3 study of osimertinib versus standard of care EGFR TKI therapy as the first-line therapy for EGFR mutation positive, locally advanced or metastatic non-small cell lung cancer. A rather large trial, 650 patients, randomizing 1-to-1 to the osimertinib, the third generation agent, EGFR tyrosine kinase specific, also by the way with very good brain penetration, versus the first generation drugs, erlotinib or gefitinib, physician choice. The primary endpoint of the trial was progression-free survival. Secondary endpoint was overall response rate, overall survival, and quality of life. Well, here are these data, and you can see the improvement is seen in both PFS and OS, both statistically significant. Here you can see the progression-free survival on the upper left, the upper curve being the osimertinib, the bottom curve being the erlotinib or gefitinib. You can see a very significant improvement in progression-free survival, and it took a little bit longer to mature, but here's the overall survival result on the lower right, and this is the first approved mutation-positive drug, the FLORA trial. This drug became approved on April 18th, 2018. Now, what about the early stage setting? With that as a backdrop, why not use these drugs in the adjuvant setting, given what we already heard from David about the results with chemotherapy, although clearly I think we would all agree we could do better. Well, these trials have been done. This is the RADIANT trial. This is adjuvant erlotinib versus placebo in stage 1B to 3A, EGFR wild type and EGFR mutation positive non-small cell lung cancer. So initially in the intent to treat population, EGFR mutations were not selected for. So you can see if you take all patients, regardless of whether they have an EGFR mutation or not, and you give them erlotinib or placebo after surgery, you can see the disease-free survival is unchanged. That doesn't surprise me at all. However, in a subgroup of these patients who were EGFR mutation positive, here you can see in yellow those patients who got erlotinib versus blue those patients who got placebo. And you can see the hazard ratio is 0.61 and borderline significance. But again, this did not reach survival as a statistically significant result. So some activity here, but notice the hazard ratio, 0.6. Most of the patients who recurred, or many of them, had brain metastases. So that led to the SELECT trial. This is a single-arm trial, so it's a little bit harder in a phase 2 single-arm trial to make much of it. But here you can see patients who received erlotinib, and here you can see there does seem to be a stabilization, 2 years of erlotinib in patients. This is the disease-free survival curve, and here you can see it by stage 1, stage 2, stage 3. So this told us that there did seem to be something there, using erlotinib now for 2 years in mutation-positive patients. Adjuvant trial. This is an interesting trial. It's from Asia, a phase 3 trial of adjuvant gefitinib versus vinorelbine cisplatin in stage 2 and 3A with N1 and N2 nodes, EGFR mutation-positive non-small cell lung cancer. So in this trial, patients, it was an alternative. Did you receive the EGFR inhibitor or did you get the chemotherapy? And here you can see the progression-free survival result, which actually favored the patients who got the gefitinib, shown here with a hazard ratio of 0.60. This was just recently reviewed and analyzed for overall survival, I believe at 5 years, and actually the curves came together. So a definitive study needed to be done, and that's where the ADORA trial came in. And as one of the authors, I'm happy to present it here today. So this was a phase 3 trial for patients with stage 1B, 2, or 3A non-small cell lung cancer, patients with or without adjuvant chemotherapy. And you'll see that's a very important point. About half the patients received adjuvant chemotherapy, equally balanced between the groups. The key inclusion criteria: age greater than 18 or in most countries, or more than 20 in Japan and Taiwan, good performance status, confirmed primary non-squamous non-small cell lung cancer, deletions in exon 19 or point mutations in exon 21. So just 2 different mutations were allowed, exon 19 deletion and L858R. Brain imaging was done, if not completed preoperatively. Complete resection with negative margins. All these patients needed to have an R0 resection. And the interval between the time of surgery and randomization was 10 weeks if there was no adjuvant chemotherapy given, or 28 weeks with adjuvant chemotherapy given. There were 3 stratifications by stage: stage 1B versus 2 versus 3A, about an equal number of the 3 groups. The EGFR mutation type, the deletion 19 or the point mutation exon 21, and race. 2/3 of these patients were Asian, so it was stratified for Asian versus non-Asian. A very simple trial. Patients were randomized to either osimertinib, 80 milligrams once a day, which is the same dose that's used in the metastatic setting I just showed you, or to a placebo. Why a placebo? Because as I just showed you, there had been no standard of care prior to this from any trial. 682 patients in this study. The planned treatment duration was for 3 years of the osimertinib, a little bit longer than the other drugs because it was better tolerated, this osimertinib, Also, remember, we believe this has good CNS penetration. I'll get to that later. Treatment continued until disease recurrence, the treatment is completed, or discontinuation criteria were met. Follow-up was until recurrence, week 12 and 24, then every 24 weeks for 5 years, and then yearly. And then after recurrence, every 24 weeks for 5 years. The primary endpoint, disease-free survival by investigator assessment, because it was placebo-controlled, in stage 3A patients, designed for a hazard ratio of 0.70. Because based on the RADIANT trial I showed you, we figured that a 70.7 or a 30% improvement would have been enough. Secondary endpoint, DFS in the overall population, so adding in stage 1 patients, and then landmarks of DFS at 2, 3, 4, and 5 years, of course, overall survival, safety, and health-related quality of life. Why are we talking about this today? Because the Independent Data Monitoring Committee met the first week of April for a safety review. But then I got a call that they decided to unblind the trial early because they did an unplanned interim efficacy analysis because they saw signs of such positive results. At the time of the unblinding, the study had completed enrollment and all patients were followed for at least 1 year. Well, here are the baseline characteristics, and just to point out, all equal between the osimertinib and the placebo: sex, age, smoking status, smoker or non-smoker. You can see there were some smokers on this trial. About 2/3, I told you, were Asian. Performance status was 0 to 1. 2/3 were 0. Staging 1 to 1 to 1. Stage 1B, 2, or 3A. The histology, all these patients had to have non-squamous tumors. You can see the EGFR mutation type, exon 19, a little bit more common. And very importantly, adjuvant chemotherapy, 55-45, 56-44. About 55% had adjuvant therapy, but no difference between the two groups. Well, here's the result, and I remember the first time I saw it, I was pretty impressed. I expected this to be a positive trial, but not at this magnitude. The blue curve being osimertinib, the yellow curve being the control, 90 to 45 at 2 years, a doubling of the disease-free survival. Hazard ratio 0.17, p-value 0.0001. It's only 33% mature because it was unblinded early, and of course most of the patients who had progressed were in the placebo arm, but quite a significant result in stage 2 and 3A disease. Then in the secondary analysis, even when you add in the 1B patients, the patients who we already know would do well, perhaps half of these patients are cured just with surgery alone, you can still see the dramatic difference: osimertinib in blue, placebo in yellow. Hazard ratio 0.21. Actually, it was just updated at ESMO, 0.20. So an 80% improvement in disease-free survival. So a very, very significant result. Then you look at a forest plot, and this actually looks at the result across a number of variables, some of the stratification factors, for example, and some of the factors I showed you earlier. But you can see to the left of the line favors osimertinib, and you can see on every single variable, it's favoring the osimertinib, whether it be sex, age, smoking status, race, stage. Even the stage 1s make it, and actually on the updated analysis, this moved even more to the left: EGFR mutation type, and importantly, adjuvant chemotherapy. Yes or no, you can see both significant results of about the same order of magnitude. Here you can see the 2-year disease-free rate, stage 1B, 2, and 3A. What you actually notice is the osimertinib result doesn't seem to change much between the stages. But look at the placebo. As you would expect, the patients are dropping off much more quickly in stage 2 or stage 3A patients. By the way, this is version 7 of the staging system. We will update it at some point using version 8, but when we started this trial 5-6 years ago, we were using version 7. And you can see 0.5, 0.17, and 0.12. The same thing we saw from David earlier, that as you get to the more advanced stages, the hazard ratios are usually better for adjuvant chemotherapy. And here are the survival curves, the disease-free survival curves. Stage 1B, of course, with the least benefit, but clearly a benefit. Stage 2 and stage 3, basically just showing graphically what I just showed you on the prior slide. Here you can see disease-free survival per investigator assessment with or without adjuvant chemotherapy. And here you can see patients with adjuvant chemotherapy, and here patients without adjuvant chemotherapy, and you can see the results are the same for both. This is actually a bonus slide because we had it in the discussion set for ASCO, we did not put it in have room for it in the actual presentation. But this is going to be a very important point as we discuss this going forward, and we're in the process of looking at these patients even more carefully. Now here's an early snapshot at survival. I was unsure whether I should even show this. It is in the manuscript, and basically you can see that with this early analysis, 5% maturity, the blue curve are the patients who got osimertinib versus the yellow, the patients in the control. The hazard ratio at this early point is 0.4, but this needs much more maturity. The trial remains blinded at the level of the patient and the investigator, and this trial will go forward because we do need to follow this trial for survival. That will happen. I anticipate that will be several years. In the meantime, anyone who fails on the placebo arm, the trial has been amended to allow them to get osimertinib on trial. And then safety is very important, and here you can see osimertinib versus placebo. There, of course, will always be a few more side effects when you compare a drug to an inert agent, but what you can see is if you look at a couple of these, AE leading to death, 0 versus 1, actually more in the placebo arm, and any AE leading to discontinuation, 11% versus 4%, adverse event leading to dose reduction, 7% versus 1%. But really, as expected, very well tolerated. This is targeted therapy. On this slide, you can see all causality adverse events using a tornado plot. The median duration of exposure is quite high, 22.3 months for the osimertinib arm and 18.4 months for the placebo. What you can see is that there are slightly more low-grade adverse events with the osimertinib arm on the left, but it's the dark blue line that are the grade 3 and 4 events, and you can see only slightly more, 1 to 2% for diarrhea, paronychia, stomatitis, decreased appetite, upper respiratory tract infection, things that you would expect with an EGFR TKI. Importantly, grade 1-2 interstitial lung disease was reported in 10 patients, all low grade, so only 3%. That was a concern, especially in Asia. Patients were not allowed to receive port radiation therapy in this trial. We were ahead of our time because the LungArt trial just presented a few weeks ago confirmed that that was not always required. And then QTc prolongation was reported in 22, 7% of patients in the osimertinib arm, and 1% of patients in the placebo arm. So the conclusions, adjuvant osimertinib will provide a highly effective, practice-changing treatment for patients with stage 1B, 2, and 3A EGFR mutation-positive non-small cell lung cancer after a complete tumor resection. Disease-free survival benefits of 80% or more. It didn't matter whether the patients received chemotherapy or not, and a tolerability profile which makes this a drug that can be given for long periods of time, i.e. the 3 years required by the study. These data actually were published online in the New England Journal of Medicine, so all those data are available in even more depth there. Now work continues. I'm about to show you local versus distant recurrence. As surgeons, I'm sure people are incredibly interested in that. What are the sites of disease recurrence? The distant sites, brain, liver, and bone. I'll go through a little bit of that right now. We're still in the process of analyzing subsequent therapies and, of course, looking at quality of life. I expect we'll have these data later this year, perhaps early next, perhaps at the ISLAC meeting, which will be virtual from Singapore. Of course, the trial, as I mentioned, continues to be followed for survival. But the type of recurrence is key in lung cancer. And on this slide, you can see that the brain is a key site of recurrence, especially with tyrosine kinase inhibitors. Why? Because many of these drugs don't get to the brain very well, or if they do get to the brain, they're highly protein bound, and they don't have effective levels to be active. And what you can see here is that at the ESMO 2020 meeting, we actually updated these data. Dr. Suboi, my colleague and friend, a surgeon from Tokyo, updated the data to show sites of recurrence in the ADAURA trial. So here you can see the types of disease recurrence. 11% of the patients in the osimertinib arm had disease-free survival events, disease recurrence or death, versus 46% of the patients in the placebo arm. In the osimertinib arm, the majority of patients with recurrence had local regional recurrence only, with only 38% of patients having metastatic recurrence compared with 61% of the patients in the placebo arm. So that makes sense. We have an active drug. We know it works systemically. There are going to be fewer metastatic sites. And one of those sites we wanted to focus in on was the brain. So here you can see a tornado plot that looks at the sites of recurrence. So you can see disease recurrence at any location up above. I just mentioned that 11 versus 46 percent. But then you can see the lung, the lymph nodes, the CNS, which I've highlighted because I'm going to show you more data, the bone, all sites of metastatic spread. Well, looking at CNS disease-free survival events, overall 45 patients, 6 in the osimertinib arm and 39 in the placebo arm, had CNS disease-free survival events. And you can see that here, 4 versus 33. So as we expected, the drug is preventing metastases in the brain. Let's look at this in a more quantitative way. So this is an unplanned analysis, you have to take it with that. But if you look at the CNS disease-free survival in the overall population, and this is figure 3 of that New England Journal paper, you can see that the osimertinib arm on the top, survival without the brain metastases, and the placebo curve is the yellow one below. And you can see the hazard ratio is 0.18. So an 82% decrease in brain metastatic disease. And then if you look at the conditional probability of CNS and non-CNS recurrence, you can see that the estimated probability of observing CNS recurrence in the absence of non-CNS recurrence or death at 18 months was less than 1% with osimertinib versus 9% with placebo. It's the line all the way at the bottom. So really a fantastic result. So updated at ESMO, again, a hazard ratio of 0.18 in the brain for disease recurrence, 82% decrease in brain metastases, certainly something that I believe would be of great morbidity to patients. And we concluded the reduced risk of local and distant recurrence and improved CNS DFS reinforce adjuvant osimertinib as a highly effective, practice-changing treatment for patients with stage 1B, 2, or 3A EGFR mutation-positive non-small cell lung cancer following tumor resection. Now, other notable trials assessing EGFR-targeted therapy in early-stage settings are shown here. This is the Alchemist trial. It's being run through the National Clinical Trials Network. There are actually a number of arms of this. Actually, one arm was looking at erlotinib. That's ongoing, although I think at some point it might be difficult to accrue that trial given these data. There's another arm looking at crizotinib, ALK inhibition, and a third arm, which everyone's very anxious to see, called ANVIL, which is looking at a PD-1 inhibitor. And now there are even new arms looking at combinations of chemotherapy plus immunotherapy. So other trials are ongoing. The adjuvant setting is a very fertile ground because we're taking already curable lung cancer and hoping to cure more patients by avoiding metastatic disease. It's the paradigm we've always hoped for using specific targeted therapy. Well, now let's turn it back to David for a discussion of integrating EGFR TKIs into multimodality treatment in earlier stages of lung cancer in the context of multidisciplinary care. David?
Thank you, Roy, and thank you for a great presentation on the ADAURA trial. So I think for surgeons, what we're talking again about is an opportunity to really improve the outcomes of our patients after they've had a very good operation, but have bad disease and are likely to recur. And again, it's possible that we, with appropriately selected patients with these EGFR mutations or perturbations, could be cured, or at worst, controlling or delaying their disease. But there's a lot of questions that I think and that I have, and a couple things that I wrote down here I want to get Roy's thoughts on. Is the effect really going to be the same in different stages? I saw the 1B. It's early. We don't know for sure, but it was already statistically significant in terms of disease-free survival. What do you think? You think the 1B is going to hold?
I do. Of course, that's the group of patients, who have the greatest chance of cure on their own. But in the updated analysis that was presented at ESMO and is in the paper, the hazard ratio was even a bit further to the left. So my hope is that it will, and that would be great because that's a group of patients, who might not need chemotherapy and perhaps could get away just with an EGFR inhibitor themselves.
Exactly. Yeah, particularly because the benefit in the LACE analysis for the stage 1Bs with adjuvant chemotherapy in terms of overall survival was, as you know, about 3%, making it hardly interesting to a patient to receive that with the associated toxicities. But here, so well tolerated, I'm hoping the overall survival for that earlier stage disease will hold.
Right. We'll need
I
to
was,
see.
go ahead, Roy.
No, well, we'll need to continue to follow longer, but I agree with you. I'm very hopeful for that too.
The duration of the OC 3 years, most recurrences occur within 2 years. Some reports out to 3. Do you think that patients are going to need to take this for 3 years?
Well, that's the biggest question I think here, how long to treat. And when we designed this trial, we scratched our heads how long to treat for. Some of the prior trials I showed you treated for 2 years. We felt pretty strongly we could get away with 3 years with this drug because it was better tolerated. Osimertinib being a more advanced generation drug, it has cytostatic but also cytotoxic properties. And the hope is using it in this earlier stage, in disease that's more driven by EGFR, less heterogeneous. We are, killing more tumor cells, and hopefully we're curing more patients. Do we need the full 3 years? It's really hard to say. I think what we're going to need to do is wait for the full data set and wait for maturity to see that. The other thing that's very exciting, David, is we do have blood on many of these patients. Some countries, we couldn't get it, but we do have blood and we can look at minimal residual disease and follow that. So that's an analysis that's going to be ongoing. So if we see the clones of EGFR mutant cells disappear earlier, perhaps we could get away with a little bit less. Alternatively, there might be some patients who might need more. Maybe their tumors become resistant, and we'll need to know what those resistance mutations are. But right now, the trial's 3 years. That's what we're doing. But it would be hoped that we could personalize that even more in the future.
Yeah, you got ahead of me. I was going to ask you about MRD or minimal residual disease and checking the ctDNA for the. So it sounds like you thought about that, and in the trial you've collected at least some blood periodically that will be part of some type of secondary analysis.
Yeah, we have blood at every follow-up point. Patients have to opt into that. So, as you go through and well, everyone had a surgical resection, so we should have that tissue. So we can do a full sequencing on that now, and that'll be interesting because we'll be able to look and see, who metastasized to where based on what mutations. But it'll also allow us to do some of these bespoke models and some of these deep sequencing techniques to look at MRD. But then, of course, like in any data set, as you go through, some countries didn't allow for the collection of samples. Some patients opted out. So we're in the process of doing an inventory. The good news is I know that this was done at many sites, and I'm even trying to upgrade, our collection now for people who remain on the trial. Because knowing this result, this is going to be one of the only chances we have for patients on osimertinib to get these types of samples in an early stage setting. So we're determined to get as many samples as we can, work with the right groups to look at cell-free DNA, and this is going to be a huge scientific undertaking, but very important because it will allow us to figure out how long to treat and then what to add if patients become resistant, and perhaps we can even treat a little bit less.
I think these correlative studies are very important, so I look forward to hearing about them. A similar corollary would be are you getting tissue when the patient recurs to, again, look there for resistance mechanisms? So biopsies, core biopsies of recurrence. Obviously, that's hard in the brain, but in other sites, it should be easier.
Right. Well, if it were to happen at your site or my site, for sure, Katie Paletti here, who trained at Memorial for 10 years, we've had a rebiopsy program, and I'm sure you and Charlie have that there. Yeah. But, in many places it's optional. We're trying to enhance that, but that's going to be so important. Now, there are some samples from the FLORA trial in the metastatic setting to try to understand, what are the mutation profiles that one sees on recurrence. But we're going to try to get that here as well. And at least in my practice, and a repeat biopsy is key. There are trials ongoing now. There's one trial called the Orchard trial, which is looking at combinations of osimertinib plus other drugs in patients who are resistant, and it's based on the tumor profile because, as you know, we're seeing c-Met upregulation in many of these patients. We're seeing a new mutation called C797S. So I would recommend a new biopsy, and or a liquid biopsy. We haven't talked about that, but many times it's hard to biopsy on recurrence. The site that's recurrent just isn't that easily accessible. So as the liquid biopsies get more sensitive, perhaps those could help us too.
I think one of the things the surgeons will ask about, and I know I'm interested in, is just the additional value, additive value of the chemotherapy. So 55, 60% got it in both groups. What's your thinking on that? We talked a little bit about maybe you wouldn't need it in the stage 1Bs because we oftentimes don't give them chemo now, really, unless they're a bigger tumor. It sounds like standard of care for now is going to be to give them an adjuvant cisplatin-based chemo and then start them on osimertinib. Would you agree?
Absolutely. So if you look at the data, and we're still analyzing it, it's only been 5 months, but 80% of patients in stage 3 and 2 receive chemotherapy, and many fewer in stage 1. Now you have to wonder why only 80% in stage 3. I'm sure at your site, at my site, we try to give that to everyone. But this is a real world trial. It was done, across the globe, and there might have been patient preference or bias. There might have been patients who were not able to get chemotherapy. We need to look into that. In any event, the results, as I showed both on the forest plot and with the curves, show that there are positive results whether the patients got chemotherapy or not. Nothing I've shown tonight, though, says we should get rid of chemotherapy. I think that multiple randomized trials. I remember seeing the ANITA trial presented in the early 2000s. The LACE meta-analysis, JBR10. I'm sure if Frances Shepard was here, she'd be quite adamant. Chemotherapy is still the standard of care, and I would agree with that in the 2s and 3s. And the 1s, I think that's a little bit more of a judgment call, and we discuss it at our tumor boards. But I think chemotherapy still has to be given for now, and then the drug as per protocol. At some point, could we consider swapping? Yes, but I think we need to look at either a new trial or data that we can glean from this trial once it's more mature.
Absolutely. Let me move on. So which patients I think we know who we'd recommend adjuvant osimertinib. I guess the question is there anyone who's got a stage 2 or stage 3 that we wouldn't recommend adjuvant osimertinib? Are there any contraindications, either pre-existing medical conditions or something like that?
Well, if they have, these drugs do more in Asia than in the US, have the tendency to produce interstitial lung disease, mild QTC issues. I guess if someone really had an issue with that, but I would say no. There are very few patients who can tolerate a pill once a day, and I think that that's what makes this such a nice result.
I think, you can't do anything unless you have the tumor tested or blood that shows that you have the activating mutation. And, there's a recent survey, I think last month's JTO, from Smeltzer and colleagues on a survey, international survey, looking about genomic testing across the world. And about 50% or slightly less of patients get genomic testing. It was really good for EGFR and for ALK and ROS1. But when you go back and look at the recommendations from the American College of Pathologists, ISLAC, and the Association for Molecular Pathology, they recommend it for advanced stage and metastatic disease, and they leave it up to the institution, in essence, what to do with surgically resectable disease. So I think one of the issues here is that surgeons, if they're not testing for EGFR mutations, probably need to change their practice along with their colleagues and their disease management teams. What are your thoughts on that?
Yeah, I think that'll be one of the best positive aspects of the trial, that we will move our testing sooner. As you mentioned, it's taken many years to even get testing available throughout the globe in the advanced setting, and it's still not where it needs to be. But at sites that are doing it and doing next-gen sequencing, I think at the time of surgery, given that we have this therapy, this makes a lot of sense. And I actually believe that there are 7, uh, some would argue even 8, actionable mutations for which we have drugs now. Each day we're hearing about a new approval or a new agent. Perhaps this same paradigm can be used for ALK or ROS1 or RET, and that's why we showed the Alchemist trial to bring that point up. So yes, I would say that we've discussed this at our tumor board already, and the more we can do this in a reflex in that setting, of course the issues of cost are always an issue, but certainly it's the best time to have the most tissue to do this, and you do a nice next gen panel. I would say get a PDL1 status probably too, and maybe dare I say tumor mutation burden, and have that information in hand for personalized adjuvant therapy.
Yeah, I agree. Any other relevant issues or implications that you can think of as it relates to, your surgical colleagues?
Well, I think it's important to take care of patients in a multimodality way. You do it at your center, I do it at mine. Becoming even more challenging because we've moved a lot of our care off of a main campus, to care center and satellite sites, which is the way it should be. Patients should be cared for closer to home. But I got to tell you, this recent focus on Zoom and teleconferencing, our tumor boards here at Yale have never been better. We have better attendance than ever before, and I think we have a new standard now that people will call in wherever they are. So I think that's going to be very important. Collaboration and discussion with now molecular data based on trials like ADORA and others.
Yeah, I agree. Let's look at this case. 68-year-old man has a VATS-right upper lobectomy for what's a clinical stage T2A-N0 adeno. And on the final path, it's a T2A, but he's got a hyoid lymph node N1 disease. But it's an R0 resection, and tumor genomic analysis identifies a exon 21 point mutation. So what would you recommend next if we're in tumor board here?
Well, this is a patient with stage 2 disease, has the exon 21 mutation. This is someone who, unless there's a contraindication, probably at least 4 cycles of platinum adjuvant chemotherapy. Would you agree?
Yes, I agree.
Now, based on the ADORA data, if the drug were approved and reimbursed, I would then discuss with the patient, before the adjuvant chemotherapy, so he or she's prepared for it, that we might want to consider, giving an oral TKI, osimertinib afterwards.
Yeah, I think so. What would you think about it? I noted in the ADORA trial there were no patients, I believe this is correct, and I think you mentioned it, who received adjuvant radiation.
None at all.
So what would you do in the real world here? That you found incidental N2 disease, so it's actually a PT2A N2 M0. Would you add port?
Well, it's funny. So we just have new data in the last week, and clearly now with stage 3 disease, patient in my shop would definitely get chemotherapy. I'm sure they would with you, and then some might even do chemoradiation, and there are so many ways to do that. We would probably give port here, and that's been our practice. Although the lung art trial, those DFS curves, I don't know what you thought, clearly didn't seem to separate, and there was even a hint of more toxicity, wasn't there?
Yeah, we would in a multidisciplinary manner, I think, discuss them and probably get a consultation from radiation oncology. I think it's important, but I think the lung art trial is compelling. It's interesting.
Although there is the argument, where you do the radiation, how you do the radiation makes a difference. I bought into that many years ago when I trained at MD Anderson, so I always hold to that.
Yeah. Did you look at tumor histologic subtypes? Surgeons are always very interested in that, lipidic or papillary or micropapillary or solid. we just published a paper that looked at EGFR activating mutations, and it's dramatically different in the predominant solid histologic subtypes. There was only 5% of those patients had an activating EGFR mutation. Much more common in acinar, and obviously if it was lipidic. So any data on that you guys looked at in ADAURA?
Not yet, but this would be a great project for a surgical fellow. And it is available in the database. And as we said earlier, there are so many aspects of this that still need to be sort of uncovered. And you can imagine that we didn't have these data till April 10th. It was presented at ASCO May 31st. Paper came out September 19th. But there's still many things that we can go into. So that would be very interesting to look at. Don't have it yet.
One of the things I noted here is I think 95% of the patients had a lobectomy, and very few sublobar resections. I would think this would still hold if you did a sublobar resection, a wedge or a segmentectomy, not a contraindication. But I wonder, I thought that the overall survivals at 2 years, 100% in the OC and 93% in the placebo, were very good, actually. And I wonder if there is some subtle benefit to doing the lobectomy. No data to that, but.
Yeah, well, that again, and I'm not a surgeon, but I've spent a lot of time with thoracic surgeons. That's always been my sense. We did not allow anything other than a full lobe in this trial. If they were done, it was not planned, and they shouldn't have gone on. So that was that's something to think about. But you might think that if it was sublobar, you'd have to ask why, and look at the margin, and you just don't want to. This was not a trial for metastatic disease, but I think that now that with a positive trial, the data can be and the results can be brought to even a broader group of patients, perhaps in the future.
I noticed that the exon 19 deletions had a better disease-free survival than the point mutations. Like the hazard ratio for the exon 19 was like 0.12, and for the L858R was like maybe 0.3, 0.31. Any ideas on why OC seems to perhaps work better for the deletions?
Yeah, well, statistically those aren't comparable. So, but yeah, numerically they are different. In the metastatic setting, the exon 19s always do better than the 21s as well. And my sense, perhaps there's less chance of a secondary mutation. You've lost a piece of DNA versus just mutated at one codon. So the chance of a secondary mutation are less. It's still pretty early, but it is consistent what is seen in the metastatic setting.
I think we're just winding up now. Maybe give us your kind of takeaways, and then I'll have a few for the surgeons as well, and the disease management teams. But go ahead.
Well, I would say, I was trained at Dana-Farber by Tom Fry many years ago, and he used to show me results for metastatic disease and then earlier disease. And as you move earlier with the chemotherapy, the results always got better. So I think the key takeaway is all the therapies medical oncologists have will work better in earlier disease. And this being targeted therapy, the fact that we can use surgery, which is a targeted therapy, and now add biologically proven therapy earlier in disease to have results like this really sets a new paradigm for us. And I think that I think the key takeaway is think about it. Now that we have these data, they are DFS. We don't have survival yet, but I think the DFS and certainly with the morbidity, the potential of the sites where the tumor's coming back, this is something that we can offer to our patients. And I think that it's only possible if you think about it, if you send the tumor for sequencing and you consult the medical oncologist. But I think that this is going to become a new paradigm, and we'll see more and more of this in all the more locally advanced settings. And then, of course, neoadjuvant setting therapy is something to think about in the future as well.
Yeah, I agree, Roy. I think for the surgeons and their teams, disease management teams, you really need to think about sending these tumors once they're resected for genomic analysis. It's critical. And I think second, you really have to be at least familiar with this topic to introduce the idea about um, targeted therapy in an adjuvant setting with some evidence, as you mentioned, which is still maturing, particularly with overall survival, to your patients, and be able to kind of set the stage when they meet the medical oncologist as to why the referral and what's the putative benefits may be. And finally, I think it's important, for surgeons to be involved in these types of trials. Just like many are involved in Alchemist, you mentioned to me before we started, you had a lot of great surgeons that work with you on this trial. So I think it really is an opportunity for the surgeons and the broader multidisciplinary team to work together. So
Well, one of the reasons it accrued so well in Japan is the surgeons there actually give the targeted therapy themselves.
yeah, I know that.
And this all these trials, it's key to collaborate with surgeons, and I think we're going to see more and more of that. And I can tell you in our group here at Yale, maybe a little smaller than what you have in New York, we have a weekly lung cancer research meeting aside from tumor board, and our surgeons and radiation oncologists are there, and we rotate the leadership of these trials because it's the only way that we're going to make the next level of progress, because I truly believe immunotherapy is next. So wait till we start bringing the immunotherapy in, other targeted therapies, but all these trials, all this science is going to require even more close collaboration, and it's exciting.
Yeah. All right, let's take a look now and see about some of the questions that have been submitted to us by those in the audience. Here's one that audience member asks: given that those patients on the placebo arm can be cross over, if they get a recurrence, they can cross over and then begin to receive osimertinib. Roy, do you think this is going to impact your overall survival data?
It could, and but that's fine, because we want to replicate what can happen in the real world. And I think we're going to make sure that any patient who does fail on the placebo arm gets access to that drug. It is, however, my feeling that given the results as I've shown them, with the hazard ratio so low at this point, the chance of this not meeting overall survival, I believe, is quite small. Although the curves will come together, and my hope is that with an active drug that works in the brain, both cytostatic and cytotoxic in earlier disease, that there'll still at the end of the day be a survival result. But we need to follow that, and that's why we have to maintain the integrity of the trial and continue to follow these patients. But in the meantime, I really hope that our patients will have access to this and ability to use this to prevent their cancer from coming back even after a very good surgery.
Okay, here's another question we have. Is it recorded, or do you know if the surgical resections, how many were done minimally invasively, meaning like VATS or robotically, versus an open thoracotomy?
That's a great question. I've looked at the database and don't want to misquote, but both were done, and it looks like it's a pretty equal number. But that's something that will come out at some point. And one of the three steering committee members on this trial, Masahiro Suboi, being a surgeon, is very intent on looking at those data. So this was done around the world. Some of these were very massive resections, and some of them were very minimal. But we'll get those data.
Good. Here's another question coming in. Any quality of life or patient-reported outcomes that are being collected? I think it'll be important to hear the perspective of the patients. About how they tolerated the osimertinib and their quality of life. What can you tell us about that?
Well, that's very important, especially as we await the survival result. The quality of life data were carefully collected. We're reviewing them now, and we've actually submitted those data, for the ISLAC, the International Association for the Study of Lung Cancer. That meeting would have been last month, but it will now be January virtually from Singapore. So we'll hopefully present it there. So there are still many analyses that will come from that, and I agree with you. The quality of life is quite important, and especially in an adjuvant trial, isn't it? That's a very important time. It's different in a metastatic disease, but an adjuvant you want to look at that very carefully. So we will have that.
Another question here is, I'm just reading this. One of the audience members is as saying it looks like there was a little more loco-regional recurrence within the OC group, very little distant recurrence, but more loco-regional recurrence compared to the placebo. My own take on that is probably there aren't really enough recurrences in the OC group to make much of it, but what do you have any additional thoughts on that?
Yeah, the audience member is very observant, and that was initially my thought too. Looked at a number of different data sets in EGFR mutated disease, and we actually quote them in the paper. It wasn't much different, but I think your answer is exactly that. When you only have so few recurrences at this point, I think let's wait till we have more. I think it could just be a numbers thing in these percentages.
Yeah. Here's a question coming in. The question is, so if I have a patient that I want to put on osimertinib in an adjuvant setting, and I want to do this, can I do this today, or will the patient have to pay for it?
Well, you can do this today, and in fact, I know that people are doing it, already. In fact, I know on York Avenue, I'm sure you do it sometimes, and we do it here on Cedar Street. That said, this awaits approval by appropriate regulatory authorities, such as the FDA, and if that happens, usually reimbursement follows. But yes, without an approval, it's not guaranteed to be reimbursed, and that is an issue. So we are waiting for those reviews.
Terrific. Okay, those are the questions that I have. And again, thank you, Roy, very much for being a part of this important event.
Thank you, David. It's been great to be here and to participate in this program.
Thank you very much, and have a terrific day.
This activity is jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/GKC860.